So, welcome to the third day of our March webinar. It's going to be today about the endovascular therapy of ruptured aortic aneurysms. I would like to welcome you all to this really great session today with an outstanding faculty, outstanding talks, and I'm just going to resume a little bit the second day where we talked about open surgical procedures. We had great talks. One was about an overview for the evidence of the surgical treatment in ruptured aortic aneurysms, and we heard about the ESVS guidelines that you should treat ruptured aneurysms whenever possible with endovascular therapy and should do it in local anesthesia. Then we had a really great presentation about ethical considerations in ruptured aneurysms, where you have to decide between the patients that are capable of decision making and not capable about decision making, and we heard about factors that are influencing the outcome in open repair for ruptured aneurysms with patient-related factors, aneurysm-related factors. And we heard about from Soran about the balloon occlusion, how to do it, and that there are some pitfalls that have to be considered and that you should do that in team for team training. Christian Reeves talked about connective tissue diseases and ruptures there, that there is small, but there is a role for endovascular therapy, especially in ruptured cases. And Jörg Schmidtli in the end talked about aortoduodenal fistulas, where you also should primarily do it with an endovascular therapy and then with a staged repair, do the bowel repair and afterwards the explantation of the stent graft and the aortic repair with biological or with deep vein material. So then was from Terumo, there was a sponsored talk about a new arch device with a single branch, very interesting one. And yeah, today, so we're already within the topic, arch device, and not so much today, but the endovascular part is our main topic today. And I like to welcome the faculty and especially the chairman with Stéphane Houlon. Thank you for joining us, and Konstantinos Donas. It's a pleasure to have you here. I know in Germany, I see it outside of your window. There's a lot of snow now, so perfect that you made it. And I'm going to introduce the first presentation. It's from Christos Kakos. He's talking about factors that influence endovascular management of ruptured aortic aneurysms.
Apologies, we will have this up in a moment. Our systems are a bit slow. Thank you.
To thank the organizers for the kind invitation. Recent American and European guidelines recommend EVA as the first option for ruptured abdominal aortic aneurysms. And if we want to improve our mortality figures, we should know which factors influence the results. There are many, but for the sake of time, I'm going to focus only on the most important ones. Imaging is important for EVA. In stable patients, there is no controversy. We all agree that CTA is the imaging of choice. The key point here is that we should image the entire thoracoabdominal aorta to be better prepared and avoid any surprises. With regard to unstable patients, most are still stable enough to have a CTA so that we can determine whether they are suitable for EVA. This is preferable because EVA in an unstable patient seems to be associated with a lower mortality compared to open surgical repair. Those not stable enough for CTA should be transferred directly to the operating room for emergency open surgical repair or an intraoperative angiogram with or without an aortic occlusion balloon to determine whether they are suitable for EVA. If not, we should inflate or maintain an aortic occlusion balloon and proceed to open surgical repair. If yes, we should select our radiograft based on measurements obtained either via fluoroscopy or intravascular ultrasound. However, to be honest, this is an extremely rare scenario. Permissive hypotension is equally important. This is a policy of delaying aggressive fluid resuscitation until proximal control is achieved. The aim is to limit excessive bleeding by allowing clot formation and avoiding the development of iatrogenic coagulopathy. Both societies, both the SVS and the ESVS, strongly recommend this policy. The type of anesthesia is one of the most crucial factors. EVA for ruptured cases can be done under local anesthesia, and this prevents circulatory collapse caused by the induction of the general anesthetic and promotes peritoneal tamponade. Several studies, including the IMPROVE trial, the UK National Vascular Registry, meta-analysis, and guidelines recommend local anesthesia as the anesthetic modality of choice, since it is associated with a lower 30-day or in-hospital mortality compared to general anesthesia. Hemodynamic instability is a significant risk factor for death after open surgical repair, but is also a risk factor in EVAR cases. There is no uniform definition what constitutes hemodynamic instability in the literature. In some papers, there is no definition at all. Others use different cutoff levels of systolic blood pressure and decreasing level of consciousness, cardiac arrest, or severe arrhythmia. Whatever the definition is, approximately a third of the patients are unstable at the time of intervention. As expected, unstable patients fare much worse than stable patients, and the more unstable EVA cases you take on, the higher the mortality of the center is. Device configuration may also influence the results. Bifurcated devices seem to be superior to aortounialiac devices and should be preferred. A good reason for this is because bifurcated devices are the ones that we routinely use for elective EVA and with which the operating team has significant experience. Aortic occlusion balloon is an important adjunct in hemodynamically unstable patients and can be life-saving. The transfemoral route is the most popular. Evidence suggests that studies with a high rate of aortic occlusion balloon use have lower mortality. That's why the guidelines recommend that an aortic occlusion balloon should be considered in order to stabilize unstable patients. Abdominal compartment syndrome is another risk factor for morbidity and mortality, and that's why we should monitor intra-abdominal pressure for early diagnosis and management of intra-abdominal hypertension. And if an abdominal compartment syndrome occurs, then a decompressive laparotomy is recommended. Risk factors for abdominal compartment syndrome include the use of an aortic occlusion balloon, severe coagulopathy, massive transfusion requirements, pre-op loss of consciousness, low pre-op blood pressure, and intraoperative conversion of bifurcated to an aortounialiac device. Surviving patients with open abdomen have prolonged hospital stay and may suffer considerable morbidity and mortality. A VAC system should be considered in these cases. Center experience does matter, and according to this Canadian meta-analysis, results seem to improve after 30 rupture EVA cases. Finally, we have chimneys, periscopes, and physician-modified endografts. All may expand the applicability of EVA to more complex cases, and almost completely replaced open surgery in certain centers. In conclusion, in order to set up or refine an endovascular service for ruptured abdominal aortic aneurysms, Logistics are important. We should have an endovascular on-call rota 24/7, enough endografts in stock. Team experience is important as there is a learning curve to overcome. We should have access to an operating room equipped for open surgery, EVA, hybrid, chimney, physician-modified endograft cases, and we should use local anesthesia and bifurcated endografts whenever possible, an aortic occlusion balloon in unstable cases, and we should actively monitor for and aggressively treat an abdominal compartment syndrome. Thank you very much for your attention.
That was a great talk. Alex, do we have the discussion after each talk, or do we wrap up everything at the end?
No, there's a discussion after each talk. So 3 to 4 minutes, and then we would move on if there are no more questions. So we have the chat function for the participants. They can ask questions over the chat function, and otherwise we can discuss it, and then we move on to the next one. Yeah.
Konstantinos, did you have a question in mind?
I have a question. Yes, Christos, excellent talk. You have an advanced experience in ruptured AAAs. So the question is, you showed us that we need we have many options and many tools in armamentarium. So it is a question, what is the endovascular stock you recommend for a center in order to be able to treat all these challenging cases?
Thank you, Kostas. To be honest, we don't have endografts in stock at the moment. It's funny we say that, but we have, to answer the question, first of all, is that we should use 1 or 2 type of endografts that you are familiar with. One type, for example, we use the endured from Medtronic, and we use the excluded from Go. We don't have at the moment, due to hospital regulations, a stock in the hospital, but we do have one. The company rep from Endurance is on call round clock in the city. Once we have a rupture case, we alert them and we tell them quickly which are the standard graft that we have. So they have a rupture kit. We bring it in with the endograft. But to answer the question, if in an ideal world, if you have in stock in your hospital, this should be done with one type of endograft that you are very familiar with, not only you, but the whole team, the surgeons, the nurses. So you have to have a range of sizes from small aortas to the larger one, and enough limbs to accommodate all of the anatomical difficulties. You should have an aortic occlusion balloon, and you should do that very, very quickly.
Christos, for complex cases, you talked about various options. We have the T-branch off the shelf, but for those cases with juxtarenal or short necks, we've been using the in situ laser fenestration. I don't know if you have any experience with that, but it's really useful for those borderline cases. If you put a standard endograft, you end up with a type 1 endoleak, and it's just a never-ending story. Whereas with the laser fenestration, you can actually get the seal at the level or above the visceral vessels.
Yes, you're right. Thank you for your observation. This is a very good suggestion. We don't have personally, and our team doesn't have that experience, but this is a very good option once you get to know the technique. We do, if in these cases, sometimes we have to do chimneys because we don't have access to other options. But this is a very good suggestion.
Okay. Should we go to the next?
Please, sorry.
No, I think to be on time, should we go to the next talk? I know we can speak hours and hours. It's a very interesting topic. So the next talk will focus on the access. It's very important, the vascular access. treatment, and Albert Busch from Germany will present the next talk, vascular access for endovascular treatment.
Access for endovascular treatment at this very symposium. This is of course very crucial in the management of aortic rupture nowadays. Why do we need vascular access? The European guideline nicely summarizes all the data comparing EVAR and open surgical repair in the setting of ruptured AAA, and you can see that EVAR outperforms open surgical repair in most study, and so both the European and the SVS guideline strongly recommend EVAR over open repair in the setting of ruptured AAA. Preoperative planning is of course necessary to establish your diagnosis. You want to make sure you have landing zones distal and proximal to the segment that you're going to treat. You want to look at possible pitfalls such as high calcification, stenosis, and vessel diameters. And of course, you want to check for anatomic variations in the supraaortic branches, in the iliac branches, and of course in the visceral segment, where we do see quite a lot of these. The standard access for endovascular treatment, of course, is femoral, and you want to make sure you end up in the common femoral artery. And if you use X-ray guided puncture, if you aim for the middle of the femur head, you will be above the bifurcation in 99% of all cases. And the same goes for ultrasound guided puncture. If you make sure you have your vessel, you have your femur head below, you will have about 100% success rate upon first try for femoral access. Standard access from the upper extremity, we have learned that left upper extremity might have lower stroke rates than right or bilateral access in a big meta-analysis. Looking at endovascular procedures in the VQI cohort, this was quantified to about an 8-fold increase of increased risk of stroke comparing upper extremity to femoral access. And looking at more complex procedures, there has not been a difference regarding where on the upper extremity you puncture, so using brachial axillary arteries. This patient cohort actually could not show a difference comparing right to left arm access, but of course also higher stroke rates using a carotid access. The use of puncture versus cut down in this upper extremity or carotid access is of unclear significance, very contradictory data and here. Percutaneous versus cut down. All of you are of course familiar with both procedures and use them on a daily basis. Vascular closure devices, performance is influenced by of course BMI, by vessel calcification, and of course also a steep learning curve of about 20 to 30 procedures depending on what device you actually use. In a Cochrane meta-analysis from 2017 comparing percutaneous versus cut-down EVAR, there has not been any significant difference on any of those outcomes. Except for procedure time, so percutaneous EVAR is faster than cut-down EVAR, and the length of stay after a percutaneous procedure is lower than for a cut-down procedure. If you need to do a cut-down, make sure to use a transverse incision in favor of a longitudinal incision, which might also reduce procedure time, blood loss, and length of hospital stay. But of course, we have learned that local anesthesia might be better than general anesthesia, so also take the way of access into consideration when doing those procedures. Bailout strategies, and this is something that is very important. I've actually learned quite a bit from putting this presentation together. Cracking and paving in highly calcified iliac arteries. You induce rupture once you have established a wire through those vessels, and then line those vessels with covered stents. Of course, you can do an open surgical conduit to the iliac arteries with a little retroaccess. You can do this endo conduit technique, perhaps in combination with cracking and paving, and after your procedure, basically sewing this prosthesis to the femoral bifurcation. You have multiple ways to establish new wires and new sheaths for an already existing puncture. By putting additional wires in and then putting two sheaths where one was before, for example, to get a balloon behind an already deployed prosthesis. Percutaneous carotid artery access is feasible and shows, of course, some rates of neurological sequelae, but probably in this patient cohort not too important, and this can be regarded as an emergency procedure. In the similar way, probably antegrade ascendens access, so you're doing a mini thoracotomy and antegrade deployment of TEVAR or EVAR in the TEVAR in the setting. And of course, you can use different ways of temporary perfusion of limbs, of visceral arteries by combining different sheaths in different direction. Here you see an example of actually taken from a publication. So you have a big diameter sheath going retrograde into the femoral here, and then you have a small antegrade puncture to actually actively perfuse this limb, which might be a rescue procedure for longer procedure. Still, in open repair, endovascular access might be of importance if you want to use your blocking balloon, and we have learned from different studies and also from a meta-analysis that aortic balloon occlusion and ruptured AAA might be helpful in hemodynamically unstable patients, and this is something that also has been recommended in the European guideline to use a balloon for proximal control in hemodynamically unstable patients in this setting. To conclude my talk, good and fast preoperative planning is crucial. Be aware of pitfalls and anatomic variations. Left arm access is always preferred, if necessary, over right arm. Percutaneous first, don't waste time on closure devices. You can always do a secondary cut down as well. Try to pick up as many bailout strategies as possible. This is something that's interesting and might be helpful at some point. And with this, I want to thank you very much for the attention, and I'm of course happy to take any questions. Thank you.
Thank you very much, Dr. Busch, for the nice overview about the access issues. Do we have some questions from the panel? Well, you highlighted the importance of when you're going to do the CT scan analysis, you're evaluating the access, and based on the anatomical conditions, which is your next step? Do you have conditions in which you're gonna say I will go for open repair, for open access?
Yeah, sure, we still do. I mean, open repair is something that's more or less established. So whenever there is not a clear landing zone, instead of probably thinking too much, of course, you should always at least think a bit, but of overthinking it, you would always try and see if the patient is stable or not, eventually put a balloon up there and still go for an open repair.
But Albert, you've shown a lot of different techniques, very interesting. In your practice, which one is your preferred when you have access issues and you have to deal with a rupture case?
So you mean if you have femoral access issues, or?
If you are concerned that your delivery system might not get up to the infrarenal aorta, would you go more for the conduit, or would you go more for the paving and cracking, or does it depend on how stable the patient is?
I guess it always depends on how stable the patient is, of course. As soon as you can establish some sort of clamp or balloon, that's probably crucial in the unstable patient. personally, we don't have that much experience with cracking and paving. In Munich, we haven't done that. We haven't done that so much, or it hasn't been necessary so far. So it's a bit hard to really see or to really talk about the value of that. I guess there are some indications, but as it has been said before, it's something you need to be used to. You need to have done before, probably in an elective setting, before actually doing it in a ruptured case.
It seems that with the new generation of low-profile devices, it's less and less an issue, because you always have at least one axis that it suits the delivery system. I don't know if it's your experience, but we've not been in the situation where we had to not perform an endo because of access for a long time.
I can't remember of any either.
Great, Albert. I think we need to switch to Kostas, but Kostas has disappeared from the screen.
The connection probably is an issue. Therefore, they turn you off the video.
Okay, but we can hear you, and probably it's because of all that snow that we could see behind you. So you are going to talk about the importance of parallel grafts in ruptured aortic aneurysm. I'm looking forward to listening to your talk, Kostas.
Thank you. And just to add, we've turned your video off to help with your connection. So that should improve your connection much more now. However, once it's time for you to answer questions or be on the screen, we can certainly try again to get you on. Thank you.
Great. Can you launch the PowerPoint, please?
Absolutely. Thank you.
Thank you so much.
Greetings to all of you. The topic of my presentation is related to the importance of the use of parallel grafts in the treatment of ruptured aortic aneurysms. I do not have any potential conflict of interest. Treatment of triplets is very challenging, especially in case of a coexistence of a compromised neck, as we can see here. Standard endovascular aortic repair is not enough. The complexity of the treatment is increasing, especially when we have more than one hostile neck anatomic features, as we can see here, a combination of a short and angulated neck or a coexistence of a rupture-threatening pathology with diameters of more than 7 or 8 centimeters. When also the axis makes troubles, as we can see here, with severe calcification and stenosis of the iliac arteries and the distal aortic segment, or here with coexistence calcification, the treatment is very challenging. And also when a ruptured pathology exists, as we can see here, with contained or free intraperitoneal rupture or orthoduodenal fistula, we have a significant limitation in the treated endovascular options. And this was the reason why we adopted the chimney or snorkel endovascular technique, defined as the placement of covered stents in the involved target vessels parallel and outside of the main abdominal endografts, as we can see here, maintaining the perfusion of the involved target vessels. The concept of the chimney technique is to lengthen the neck in a healthy aortic segment. Here's an example of a short and angulated infrarenal neck, and when we see this anatomy, additional placement of chimney graft in the involved left renal artery create a new seal zone of more than 20 mm, as we can see here, and here the CT reconstruction after the treatment with a chimney technique, leading to exclusion of the involved juxtarenal aortic aneurysm. Nowadays, the role of the chimney endovascular technique is very clear in the emergent treatment and is also confirmed and recommended from the European Society for Vascular Surgery 2019 clinical guidelines on the management of abdominal aortoiliac aneurysms. However, it is very important to highlight that the use of devices from the stock, it doesn't mean that we have the similar outcomes. So we have also, after analysis of the PERICLES registry, some clear recommendations in order to have durable results. So the combination of a flexible endoskeleton from Nitinol, as we see in here from the Endurance device, in combination with a chimney graft, with a covered stent, with a high radial force, seems to have better outcomes. The conformability of the Endurance device around the chimney grafts is very obvious if we see CT scan analysis. So you see here how the Nitinol endoskeleton wrap up the chimney graft, and you see that a configuration like this with a significant degree of oversizing minimize the area of the gutters, leading to complete exclusion of the aneurysms. Here's a nice example. You see very nicely how is the expansion of the Endurance device in these anatomies. You see the ability to expand within 5 millimeters due to the short M-shaped stents, leading to a complete filling of the gap of the aneurysm sac, and finally to disappearance of gutters in case of the completion angiography. It is very important, in order to have durable results, to respect the IFU for TEVAR. First of all, it's very important to have an oversizing of 30% in order to have enough fabric material to wrap up around the chimney graft. It is also very important to perform chimney only for single or double cases, because we have seen that in case of multiple chimneys and use of bilateral access from the upper extremity, we can have a significant higher risk of stroke, as we see here, and major adverse cardiovascular events. In case of multiple chimneys, we compared the results compared to the single or double chimneys, and we found indeed higher rates of type 1a endoleaks, chimney graft occlusions, and strokes in case of multiple chimneys, recommending the use of the technique in single or double cases. So in summary, we have to highlight that there is no doubt that parallel grafts are very important in the emergent setting, and especially in the treatment of ruptured aortic aneurysm, but also important is to respect the IFU for TEVAR in order to have durable results. Thank you very much for your attention.
Thank you, Kostas. You're back.
I'm back.
Great talk. You perform those chimneys from the arm, as you just showed, well, from upper excess. Did you kind of change your practice now that cerebral sheaths are available? Do you consider using those to perform exclusively those chimneys from the groins?
Yeah, this is a very good point. It is, of course, very attractive to perform it from the transfemoral axis. However, I have to say that there is some issues. For example, you have, due to the fact that we are deploying the device outside of the main abdominal endograft, there is a risk of interaction of the balloons, of the balloon-covered stent with the pins of the suprarenal stent. And in this case, you can have a really devastating complication. So I need, there is an option, however, is technically not so easy to do it, because we have to deploy it before the full expansion of the endograft. And this is technically very complicated. There is an option, the lift technique, when we are deploying self-expanding stents, and Zoran Ranjic knows the technique from Zurich Group. However, you know, also self-expanding covered stents have a poorer radial force compared to balloon expandable covered stents. So I think it is at the moment premature to recommend a transfemoral access. there is no doubt that in case of using this access, we will have benefits avoiding the access from above.
Great. And on the same topic, there's a question from the panel. What kind of parallel stent graft do you use? Advanta, Bentley? Would you recommend one or the other?
There is no doubt that the major experience which we have done is with the use of the Advanta Atrium. However, the use of the Bentley covered stent is also a promising option because they are very flexible, and based on this, you can avoid additional lining of the more rigid Advanta devices. And you can imagine, Stefan, you have per se a compression from the abdominal endograft in the chimney graft, and if you put additional stent to improve the transition in angulations, you have a very narrow patent lumen. So based on this, I think the use of the Bentley devices is promising, should be evaluated. We published the 1-year experience, but of course we have to see the long-term performance.
Great. Kostas, I don't see any other question.
Stefan,
Alex.
Can I just ask a question? Kostas, thank you very much for your great talk. So chimney grafts is your baby in some kind. And what I wonder is, because one of the big critics about chimney grafts are the gutter endoleaks. And I think gutter endoleaks is something in elective cases is with a wait and see strategy, that's okay, because we know that a lot of these gutter endoleaks will seal over the time. But in ruptured cases, I think gutter endoleak it's a 1A endoleakage, and so do you have any opinion on that? Did you experience any persistent bleeding with gutter endoleaks, or do you just say that will seal within hours and you don't have a problem?
No, this is a very good comment, Alexander. You are absolutely right that in the ruptured cases, you have per se a disorder of the bleeding of the blood condition, and you have probably higher rate of endoleaks, especially type 1A. I think it's very important to highlight these IFUs. So you have to oversize. We published this week in the European Journal the 30%. You have to have an aggressive oversizing to have enough fabric material around the chimneys. You have to build and create a new seal of 20 millimeters. So in these cases, even if you have an endoleak, I'm not expecting to see this in the post-op CT follow-up, because you have the main, let's say, preconditions. You respect the preconditions, and based on this, we learn that the endoleaks will disappear. One other option which we can do is also to have the completion angiography and have a catheter in place. And in case of persistence in the completion angiography of gutter endoleaks, you can additional use, especially for this indication in the ruptured case, additional coils in order to be 100% sure that it will be disappeared. So my recommendation is to focus in the preoperative planning and sizing. This is our new study, the Protagoras 2.0 in European Journal, to focus on the aggressive oversizing, 30%, good seal zone of 2 centimeters at least. And in this case, you can be sure that a possible endoleak in the completion angiography will disappear.
Thanks, Kostas. Maybe you can introduce Nikos for the next talk, because I think we're slightly running late.
Thank you, Stefan. I'm more than glad to introduce my good friend, Greek colleague, Professor Tsilimparis, director of the University Hospital of Munich. He built there a new department, and I'm not exaggerating to highlight your success in this very short time. You have an advanced experience in complex repair of aortic aneurysms. I'm more than glad to hear you about the utility of the physician-modified devices for these pathologies. Dear Nicolas.
Dear ladies and gentlemen, dear colleagues, thank you for the opportunity to present on the importance of physician-modified endografts in ruptured aortic aneurysms. As we all know, in cases of a frank rupture, the open repair is the only real option, while in cases of contained ruptures, chimney for the renal arteries plus standard EVAR, as well as fenestrated branch repairs are the most common ways to go. In terms of fenestrated urgent repair, of course, there is not enough CMD device available for these patients, so an off-the-shelf device would be very much required in a lot of cases. However, this graft is still not readily and widely available. Of course, thoraco-abdominal endografts are now available from different companies, and they facilitate the repair of complex thoraco-abdominal aneurysms, but they are still not quite suitable for abdominal juxtarenal aortic aneurysms. These are the two grafts that are available in Europe right now. And the T-branch is the one that has been mostly been used so far and has an applicability in about 60% of patients with thoraco-abdominal aortic aneurysms. However, we can see that there is a huge difference in terms of how much of the thoraco-abdominal aorta you have to cover if you treat a juxtarenal aortic aneurysm or a suprarenal aortic aneurysm with a fenestrated repair, as shown here, compared to two different other thoraco-abdominal aortic endografts. And the other problem when treating a juxtarenal aneurysm with a T-branch or another off-the-shelf device is that you might compromise the bridging stents in terms of the space that is available in the juxtarenal aorta. The recommendations of the European Society of Vascular Surgery are to use off-the-shelf devices or parallel grafts, but of course also physician-modified endografts, although the level of evidence for all of these recommendations is quite low. So practically, how do you go around a case like this of an 80-year-old patient unfit for open surgery with the severe coronary artery disease who presents with a contained ruptured paravisceral aortic aneurysm? Well, since this patient would require a very extensive repair with a thoraco-abdominal endograft, we choose to go with a back table modification and a surgeon-modified endograft, as we did in these patients. And this is usually done while the patient is prepped and induced for anesthesia by the anesthesiology team. And we take the time, which is about 30 to 120 minutes, to prepare the fenestrated endograft. Of course, before that, you have to do the respective measurements as one would do with any fenestrated device in order to make sure that you accurately plan the fenestrations to align the target vessels. Then you go on the back table as we saw before, and you start doing the fenestrations and the pre-assigned positions using, in this case, an ophthalmic cautery. We always reinforce the fenestrations with a RadioPEC wire in order to make it visible during the procedure. And I always use diameter reducing ties to make sure that the maneuverability of the endograft in the aorta is exactly as good as that of the CMD devices. And we proceed with implantation of the endograft as we would do with any fenestrated device, with the advantage that you can see the markers of the fenestrations much more clearly with the RadioPEC wire. This was the 6-month follow-up of this patient with an excellent result. I currently overview an experience of 60 patients with fenestrated branch endografts that I operated on for contained ruptures or symptomatic aneurysms, in most cases with 3 to 5 fenestrations using the platform of the TX2 device with a 7% in-hospital mortality, but also some relevant late complications. One of the biggest questions that arise when using CM-FEVAR is whether the results are similar to the devices that are company made. And of course, there are major differences such as type 3 endolytics, as you can see in this study, but the long-term results are similar. One of the major advantages of surgeon-modified endografts is the versatility in the design. And this is a very nice case of a 64-year-old patient with prior Crawford operation thoracoabdominal repair with a patch aneurysm in the visceral aorta. A blown out aneurysm here contained ruptured, but reinsertion of the left renal artery quite high that made him unsuitable for a T-branch. Therefore, we modified a T-branch, creating 2 fenestrations and modifying the 4-branch device to a 2-branch, 2-fenestration device. This was the final result. And this is another modification in a bifurcated graft where we added a reversed branch for an accessory renal artery. Of course, even more complex designs have been suggested by one of the pioneers of the technique, Gustavo Oderich, as here with the internal branches for a thoracoabdominal aortic aneurysm. The total world experience with fenestrated branched devices is around 500 to 600 patients that have been published at least. That were acute in most cases, of course, with a very acceptable mortality and postoperative complications. Also in the thoracic area, there have been more and more cases described, but this is an area that is still quite evolving. However, a word of caution needs to be said when using fenestrated surgeon-modified devices because of the regulatory issues, the risk of graft contamination, stent graft integrity issues, as well as the durability in the long term. So to conclude, surgeon-modified endografts represent an excellent option for juxtarenal aortic aneurysms not suitable for open repair or off-the-shelf devices because they reduce the aortic coverage. They offer more versatility in the design of the graft than standard off-the-shelf thoracoabdominal devices, but they still need to be used only in absolute emergencies. Thank you very much.
Thank you very much, Nico, for the excellent overview and your personal experience. You highlighted, I didn't hear so well, that you are doing this preparation during the preparation from the anesthesiologist. So it would be nice to give us an overview about the needed time. And my second question is, so this means that you have to have the experience for standard fenestrated endografting, because this is a step forward. What do you recommend for a young physician or a consultant to have in order to start doing this very impressive alternative?
Yeah, thank you, Kostas, first of all, for the very flattering words of introduction. I think that it's important to have some time when trying to do a surgeon-modified procedure on a patient with a rupture. And of course, we have to clarify these are not frank ruptures, so you cannot treat a patient with a retroperitoneal hematoma with this technique unless you really take the risk. In these cases, I would not go for surgeon modified, but I would try to go for open repair. In situ fenestration is probably another option, and even chimney. But these patients do need to have some level of hemodynamic stability in order to perform this technique. Otherwise, you run the risk of losing the patient while doing the fenestration, which takes about 30 minutes for a single fenestration to 2 hours if you do a 4-vessel fenestrated device. I think that starting with the surgeon-modified endograft and starting your fenestrated experience with this is the wrong way to go. You definitely need to have an extensive experience with CMD devices before going on to do surgeon-modified. And I believe that if somebody has a case that needs an urgent treatment, that cannot wait, for example, a large 10 centimeter juxtarenal aortic aneurysm or a symptomatic juxtarenal aortic aneurysm, he already has a good experience with fenestrated devices, and he can go on with for example, a two-vessel fenestration. With two fenestrations, then it's a good way to start.
Nikos, I would like to shortly echo Kostas' nice words, and also ask you a question from the panel, which is, would you consider using preloaded wires in those acute cases?
I think that it's also an option. I haven't done it very frequently. I've done it for some surgeon-modified branched cases, but this is also an option you can consider. It just adds more to the complexity of the modification.
And last very short question was from Clark. When do you use TEVAR? When do you use T-branch? When do you use physician-modified endografts?
So in my practice, I almost never use chimneys. I only use chimneys as a bailout if I mistakenly overstand a renal artery that I didn't want to. In the acute phase, if it's a anatomy that is suited for fenestrated repair, irrespective of how acute the patient is, I would go for surgeon-modified fenestrated. If it's a patient that is thoracoabdominal with a thoracoabdominal aneurysm and is more or less suitable for TEVAR, even outside the IVUs, I would go for a branch repair. But if a patient has a fenestrated indication, even in a rupture or contained rupture setting, I would definitely go for surgeon modified.
Excellent. Okay, other questions from the panel? My final question about the bridging devices. We spoke about this. Would you recommend probably bridging devices with more radial force like the BGraft Plus, because you don't have a reinforcement of the fenestrations?
Well, actually, I do
would you go for a standard bridging device?
I still use the standard BGrafts or other bridging stents, but I use all the BGrafts peripheral also for the fenestrated cases. We do reinforce the fenestration with a gooseneck snare. And I do all this in a double way, so in a double round of the fenestration. So it actually quite good reinforcement. I think some of the type 3 endoleaks that we saw there had to do more with the more difficulty in putting the fenestration at the right place, and sometimes they're not quite round as they should be. They fall into one of the picks, and in this case you get some of these endoleaks, but we have seen that all of them occlude on a very short time.
Thank you very much. Okay, our next talk, Stéphane Houlon. You don't need any introduction. I have to say I have to take the last train to Frankfurt now, and therefore I want to express my deep thanks to Professor Zimmermann for the great honor to participate in this excellent webinar. And Stéphane Houlon will present the treatment of chronic dissections. I'm more than glad to hear your talk, Stéphane, and hear from your large experience about these complex pathologies, how to do it.
Dear Alex, dear Zoran, congratulations and happy birthday for this 10th anniversary of the Mars. Very happy to be with you today and share my experience with those challenging cases. Those are my disclosures. Briefly, we have treated a couple of arch ruptured chronic dissections with often wrapping of the ascending aorta in a couple of patients that were contraindicated for a classic frozen elephant trunk. This is the ascending wrapping. And then during the same procedure, we did a debranching of the supraortic trunk from the non-coronary sinus, providing a very long sealing zone in the ascending, and the TEVAR was implanted because it was an acute case during the same procedure. Now, in the ruptured cases, in patients that had a prior ascending repair, it is actually quite nice to reline the tube graft in the ascending with a branched endograft. And we've done a couple of those because those branched endograft are almost off-the-shelf devices. The design is always the same, and we've published a paper with Thilo Kobel showing that. A couple of examples. Using a free branch endograft here with a retrograde branch for the left subclavian artery. We have published our initial experience with the branch endograft in the arch, obviously in non-acute, non-ruptured patient, and you can see that the results were really good with a low mortality and stroke rates, but there was an Achilles heel, and this was the need for secondary procedure. And I'm quoting that because for acute cases with rupture, you will need to block any perfusion of the false lumen, for example, from supraortic trunk dissections. And you can see here positioning calls in the false lumen of the innominate trunk. Or you will need to block backflow from the false lumen below, positioning a Kandig plug. And this is an example here, and I'm going to show you the technique you need at the end of the procedure to access the false lumen, looking for a communication tear, and then position the Kandig plug in the false lumen at the level of the distal edge of the thoracic endograft position inside the true lumen. And you can see the angio, true lumen perfusion, then backflow to the false lumen blocked at the level of the Kandig plug. And this is an example of a Kandig plug in a branch arch endograft. Now, many patients will not get a seal at the level of the distal descending thoracic aorta because the aorta is too large. So for those patients, you need to reline them with a fenestrated or branch endograft. But those are quite complex procedures. You need to find your way from the true lumen to the false lumen through communication tiers. And obviously, you need 3D imaging and fusion guidance. Now, in non-acute cases, you have time to design a custom-made endograft. And for example, here the right renal fenestration is positioned at the level of the communication tier between the true and the false lumen. And then you get through the fenestration, through the communication tier to the target vessel and use long bridging stents. This is the final result here. We can also use a branched endograft. In this patient, this was mandatory because the only access to the target vessel was through communication tier position in the mid-descending thoracic aorta. This was the graft design. And you can see here the final result with branches. But for real rupture, for real acute cases, how do I deal with them? Well, first, to get a proximal seal, usually we use this off-the-shelf LSA branched endograft. This is one of an example of how to get a proximal seal here. And then we position a T-branch using groin axis with an Aptus 16 French steerable sheath. And this is quite straightforward if all target vessels are perfused by the true lumen. You can see in this video such a case. The Aptus is positioned just above the celiac trunk branch, and then a catheter is advanced, and under fusion guidance we're getting access to the celiac trunk here, and then we're going to stent it. You can see a couple of Amplatzer plugs that have been positioned in branches to avoid backflow into the false lumen. Here access to the SMA, and then all target vessel will be accessed the same way. Now, it is not always that easy because even though a target vessel can be positioned in the true lumen, you can end up in the situation where, because of a large entry tier at the level of the visceral aorta, you have one of the branches opening in this communication tier. And you can see here the left renal branch has opened in the communication tier, and you only have access to the false lumen from that branch, although the left renal is actually perfused by the true lumen. So in this specific case, I was in trouble, and I used a laser probe that I inserted from the groin between the graft and the intimal flap, and I perforated the top of the left renal flap here, and once the wire was in the false lumen, I could snare it from the branch and restore access to the true lumen. So you can see that sometimes it can be quite challenging. So for those patients, we now have an off-the-shelf preloaded branch endograft. And you will see here that with this type of device, the sheath is advanced directly into the branch, and then access to the target vessel is quite straightforward. This is the result in a specific patient. Another patient treated with a similar device. If you don't have such a device, you can position at the beginning of the procedure a wire from the true lumen through the communication tier, and you can then snare that wire from the branch axis. The nice thing about those preloaded systems is that you can tackle any challenging anatomy. You can see here using a brachial to femoral through and through axis, you can advance any type of device in challenging anatomies, and then with those preloaded wires have access directly to the branches despite all those very challenging kinks. And this is the final result. We have published our experience with branched endograft and fenestrated endograft in chronic dissections. And let me just conclude by saying that it's sometimes better to go for an open approach, especially in a young patient when with a tender, almost 8 centimeter thoracic post-dissection aneurysm, and he was fixed by a thoracotomy and just a single tube and a branch to the left subclavian artery. In this other patient with a very large thoracoabdominal aneurysm, we first fixed the thoracic portion, and then came back later and relined the thoracic portion with a branch and fenestrated endograft. So in conclusion, those cases can be simple to very complex. You need off-the-shelf device, you need quite a significant ancillary toolbox, you need 3D imaging, and obviously you need to be in a high-volume center performing both techniques, open and endo. Thank you very much.
So, Stefan, thank you for your great presentation, and concerning your conclusion from simple to complex. The good thing with your presentations is that the complex things always look simple. And yeah, so and there's one question already from the audience. And so what material do you recommend for the wrapping of the ascending aorta?
It's a Teflon sheath. So it's not a Dacron graft that we open. It's actually a Teflon sheath, and this is that was one of the big surprise when I moved from Lille to Paris, is that the CT surgeons here accept all those acute type A that are contraindicated in other centers for the standard open repair with a bypass, and they do that specific wrapping that requires dissecting the root all the way to the arch and using this large Teflon plaque. And I was very suspicious about the long-term outcomes of this approach. And well, we just published recently a 3-year outcome of almost 40 patients. And the outcomes are quite good. They have a 30-day mortality or in-hospital mortality of 9% in this very fragile group. And what is interesting is that this wrapped ascending stays, what do I say, is stable over time On the contrary, what I had seen before is we're positioning those short wrapping in the mid ascending would end up with a candy plug aspect of the ascending aorta, which was a disaster. So now that I feel comfortable that this can provide a landing zone for during a long follow-up, we've actually used that in all those cases that are borderline for an arch endografting or for a how would I say, hybrid approach. And we tend to now wrap all those 42, 46, 48 ascending. What is interesting is to perform the extra-anatomic bypass from the non-coronary sinus very low. So you end up with 7 centimeters or 8 centimeters of proximal landing zone. So you really have a long overlap between your wrapped ascending and the TEVAR in order to get a stable platform. And we've treated a couple of acute arch dissections with this technique, patient that could not have survived a frozen elephant trunk approach. Having said that, if the patient is fit enough, he will have a frozen elephant trunk as our standard approach for those acute cases.
So do you taper the ascending always down to a certain diameter, or it depends on the diameter of the ascending aorta?
So I would not use the ascending as a proximal landing zone if it's larger than 38. So anything that's larger than 38, I would taper it to 38 with this wrapping. Okay.
And to stay in the thoracic aorta, there are 2 questions about your prevention strategies for spinal cord ischemia. Do you have, or do you also do in ruptured cases, if you cover a long segment in the thoracic aorta, do you do any prevention strategies, or do you say it's a rupture, just go on?
So it really depends if we're going to tackle that rupture case with open or endo. With open, we tend to put a spinal drain almost all the time. With endo, we are less aggressive than we used to be. We now have a policy of waking up the patient on the table, or actually not getting them to sleep, and really having a close look for the next 48 or 72 hours. And we have a team here that can position the spinal drain very fast because there's a real mobility associated with spinal drain, and usually go for endo if the patient is fragile. And so if you add to those patients with COPD, with a morbid obesity, if you need to keep them for 72 hours flat, and with all the risk associated with a spinal drain, I think that you add some mobility. So we've kind of changed our approach, and we think that the balance is in favor of not putting it routinely if you have a team that can put a drain 24/7 very quickly.
Okay. And probably last question from my side, because in chronic dissections, in ruptures, I think most of the times the thoracic part ruptures, because what you experience is that the false lumen of the descending aorta will expand, and that is the most crucial area to see a rupture. And you mentioned the candy plug technique. So candy plugs are special devices from Cook. Not everyone will get a candy plug, and you can, most of the centers cannot put one in stock. So do we have any other strategies for occluding the false lumen?
That's a very good point, Alex. We have candy plugs off the shelf ready for those acute cases, but you can build your own candy plug with a classic thoracic endograph, and you can taper the mid portion, and then in that mid portion put Emplaza, very large Emplaza plugs. Nikos, I think you've published that, or at least the team from Hamburg at the time you were in Hamburg published that. And there are other options with parallel limbs in the false lumen that you also include with Emplaza plugs. So there are various options, and I agree with you that most of those ruptured can be dealt this way. The only problem is if you have a very large false lumen all the way to the visual segment, then you need to reline the thoracic endograft with a T-branch, because otherwise you will not exclude the rupture.
Okay. And last question from the audience. When do you start dual antiplatelet therapy in branched arch cases?
So if we're not talking about acute cases, we tend to do all those cases under at least aspirin. And if there's any disease in the supraortic trunk, we are quite aggressive with dual antiplatelet therapy starting right after the procedure.
Okay.
So maybe it's time for me to introduce you.
Okay, thank you.
Pleasure to introduce the chairman, Alexander Zimmerman, who will talk about EVA for ruptured abdominal aortic aneurysms, lesson learned.
Dear ladies and gentlemen, dear chairman, it is a great honor for me to speak about my personal experience in the treatment of ruptured abdominal aortic aneurysms. Here I would like not only to reflect my personal experience, but rather to validate them with published studies. These are my conflicts of interest. First of all, I believe that success in the treatment of ruptured AAAs requires many ingredients. In particular, success lies in the team play of different disciplines and skills. And since these points are so central, you will probably find them in detailed form in other lectures during the March webinar. So let's come to lesson 1. Screening works. And in this study reported here, 3,268 65-year-old men were invited for screening. Nearly 84% of these invited actually showed up for screening, and over a 5-year follow-up period, there was an overall mortality of 7.5%. While there was not a single rupture in the group of men who showed up for screening, at least 3 men who did not respond to this invitation died of a proven rupture. So lesson 2, surveillance is essential. And if you have already detected an aneurysm, then you need to continue to monitor it. In a study published in 2016 of 283 ruptured AAAs, it was found that 1/3 of these patients had previously known aneurysms. And the 2 main reasons for not receiving treatment were treatment refused by the surgeons in 36% and missed surveillance in 31%. So this leads us directly to the 3rd point, lesson 3. If aneurysms requiring treatment are not treated, rupture often represents the most common cause of death. And therefore, one should always think twice about refusing invasive treatment. And in this study, 154 patients with a treatment demanding aortic aneurysms greater than 55 millimeters in maximum diameter, who were not treated for various reasons, were follow-up. So different reasons for non-treatment emerged. One was that the poor cardiorespiratory status was responsible in up to 44%, the lack of morphology for endovascular treatment in up to 80%, and the general condition of the patient in up to 48%. But however, up to 23% of the patients also refused the invasive treatment. And if we now look at the cause of death of the deceased patients, we see that in all 3 size groups with more than 40% of the cases, rupture of the aortic aneurysm was the most frequent cause of death. Lesson 4, team training makes you better. In this 2016 published study, structured team training significantly reduced the time between patient arrival in the operating room and the start of surgery. And since we should all be aware that time in particular is a relevant component of success in the treatment of a ruptured aortic aneurysm, it should also come as no surprise that there was a significant reduction in the 30-day mortality of these patients studied. Whereas before team training, the 30-day mortality was almost 45%. After team training, it was reduced down to almost 30%. Lesson 5. Good anesthesia makes a difference. In my eyes, really, I think 3 factors play a major role here. The first one is permissive hypotension works. And the second one is the type of anesthesia procedure also plays a major role. And in this study conducted on over 700 patients, it was shown that EVA-treatable patients who were treated with local anesthesia had a significant survival advantage over patients who were treated with general anesthesia. And one point that is particularly close to my heart is blood pool management. If done wrong, it can cause a lot of problems. Because ruptured aortic aneurysms usually also require, when treated by EVA, a mass transfusion. The ratio of FFP should always, to blood cell concentration, should always be 1. And this was shown by a detailed analysis, as this ratio was associated with the best patient survival probability in a multifactorial analysis. Lesson 6, and not all endoleaks play a role. And I think type 1 and 3 endoleaks must be treated immediately after endovascular treatment of ruptured aortic aneurysms. And this also indicates the need for immediate postoperative monitoring by CT angiography. On the other hand, type 2 endoleaks do not play a role. And we evaluated our own data from 2010 to 2020, and in 169 endovascularly treated ruptured aortic aneurysms, 25 patients had a type 2 endoleak. And 40% of these type 2 endoleaks disappeared spontaneously, and only 5 patients required intervention, and none of them within the first 30 days. The interventions performed were necessary in 4 cases for the increase of aneurysmal sac, and in 1 case for development of an endoleak type 1 due to secondary expansion. Lesson 7. EVA in non-EVA candidates leads to death. And in these data shown by Benjamin Starnes, it was demonstrated that in morphologically suitable EVA patients, endovascular implantation for aortic rupture achieved a significantly better 30-day mortality than open surgical procedure. But however, when we are dealing with endovascularly unsuitable patients, endovascular treatment resulted in 100% death within the first 30 days in these patients. And lesson 8 as my last point, I think centralization saves life. Simply put, the more you do, the better you are. And on this topic, I really look forward to Matthias Trenner's presentation tomorrow. Now, I would like to thank you for your attention, and of course, I'm available for questions.
Thank you very much, Alex. I really love those crystal clear take-home message. And I think there's a lot of data to support what you were saying, but it seems that not everyone is on the same pace, and many people are pushing the endo approach, thinking that a type 1 or type 2 endoleak is not a big issue, where it is actually.
Yes. Yeah, well, I think one of the big problems is that experience and centralization makes the difference, and not only in treating the patient, but also dealing with the complications or dealing with not sufficiently treated patients. And I think you always have to have bailout strategies. And I really wonder, there are some centers that propose that they have operated. I don't know how is it in your center, but you also talked about open surgical procedures in thoracoabdominal ruptured cases and so on. But there are centers that really tell you that they haven't treated in years a rupture with an open approach. They can treat every patient endovascularly. And I think with the different strategies we have with Jiva, with physician modified, with laser fenestrations, there are with off-the-shelf devices, there are so many ways to go nowadays to treat your ruptures. But there are still cases to be treated with an open approach. And I think the experience there really matters to see where the limitations are. Yeah, that you have the different therapy strategies in stock, but also to see where is the limitation of each of these strategies. And most important is really, you don't just, if you do your endovascular approach and then you say, well, in the angiogram, everything is fine. I really saw some patients, we did an EVA, good neck, but there was however, there was a type 1A endoleak, and we just detected it with the postoperative CT scan. And I think we don't look for the renal function, because in this case, renal function is secondary. We just always, my opinion, we always go for the postoperative CT scan just to rule out an endoleakage. Probably in suitable patients, this is something you can do with contrast enhanced ultrasound. We do that also, but in the night, and depending on the surgeon who is probably not so fit with contrast enhanced ultrasound, go for a CT scan.
Yeah, or you can do a contrast enhanced cone beam CT on the table. Then that gives you quite some information. But I think that one of my important message to the young ones is don't turn a straightforward open case that will have a good outcome into a very complex endo repair, because we're talking about outcomes for patient, and sometimes just putting a clamp and doing a simple tube, it's probably better for the patient rather than going for a very complex open endo repair. Having said that, some patients are just not fit enough for any type of open repair.
Yeah, but this is also, I think what's interesting is in the patients that were follow up with an indication for treatment and they were not treated, more than 20% of the patients didn't want to have a treatment of their AAAs. And what we all in a lot of cases see is that these patients, they come into our emergency room with a rupture, with a contained rupture, and patients that you discussed several times in your outpatient clinic and discussed with them, they said, well, I'm old enough, I don't want to have any treatment. And then they come in the emergency room with a rupture, and you discuss the strategy again with them and say, oh, well, now it's ruptured, I want to have a treatment. Yeah.
So I think we're slightly running late. Do you want to introduce the sponsored talk?
Yes.